Today is a great day for me that I am introducing in the talk show today Dr. Himansu Kelkar, who is a president of Indore IAP 2020-25 and doing a lot of work in Indore and is spreading name of Indore across India. His designation as senior consultant and in charge pediatric department Apollo Hospital, affiliation Suraksha Clinic Apollo Children Hospital BHRC Life Care Barrow We Care Hospital. His special interest in the field is neonatal infection diseases, respiratory diseases, and vaccinology. All are the good branches of for the pediatrician. He's president of, as already I told, he's president of Indore IIP branch. He will be enlightening us viewers about Japanese encephalitis and why it is necessary in MP. His more stress will be on that. I hand over the program to Dr. Himanshu Kelkar. Please proceed and share your slides.
Thank you so much, sir. Thank you, and I am highly obliged and privileged to have this opportunity given by you, sir. I sincerely thank you so much. I'll move ahead with my slides. Sir, please let me know if my slides are visible.
Yes, it is visible.
I'm making it full screen, sir.
Yes,
Okay.
make it. Okay, no
So
problem.
immediately moving ahead, Japanese encephalitis. Now, this has been a growing menace, and recent talk of about encephalitis all over India. And most often, why we are worried is because where we are staying and where we are working in our workplaces, this encephalitis is growing. In many states of India, they have identified many zones, endemic zones, and Madhya Pradesh, Bhopal, Indore, Raisen, these are the hotspots. And recently, even Times has also reported that JE positive cases have been found, and they have been spreading in the community. So now this Japanese encephalitis, why it is significant at this hour is because now the monsoons are approaching, and as soon as the monsoons draw near, the incidence of this disease increases. And most important is the mortality. Why? Because this disease has a high incidence of mortality. That's why even the government has been forced to introduce this vaccine of JE in the national immunization schedule recently in the NIP. So my outline of the presentation would be to have an introduction, epidemiology of this disease, pathogenesis, how clinically this disease presents in children, how we diagnose, how we manage this case, how we can prevent it, and what are the criteria to select the best available vaccines. So introducing it's Japanese encephalitis, it is an acute inflammatory disease of brain caused by Japanese encephalitis virus, and it leads to an acute encephalitis syndrome in Asia throughout, even in India, and it is a disease of public health importance. It is endemic, as I earlier mentioned, that it's endemic in many parts of India with periodic epidemics. And that's why even like in Gorakhpur or in some northeastern states, it has been a surge. I'll again talk in upcoming slides. It has a very high case fatality. It has a high rate of complications leading to lifelong sequelae, morbidity. No specific treatment for this viral infection is there. Mind it, friends. That's why it is very important for us to know about it and treat it in time. So the geographical distribution you can see globally endemic zone in 24 countries of Asia and Western Pacific. So that's why it is very in CDC 2015, it has been declared all over the world, right? From India, Nepal, Bhutan, Burma, China, Mongolia. So this whole strip of the countries, South Korea, North Korea, everywhere except the European countries where it has the incidence has been less. All of these Asian countries have been drastically affected by this disease. So now this is the case report by WHO, and as per WHO estimates, almost 68,000 JE cases occur every year. And mind it, friends, India is on the top of the list, and the cases have been rising every year by year till 2017. However, 10% of these cases are reported. So that means the amount of cases which have been reported are the tip of the iceberg. There are many cases which have been missed or probably even not investigated properly. So the recent data indicates maximum number of cases which are being reported from India, and there is a significant underreporting. Considering the above incidents, the evidence, the actual number of JE cases in India could be in the tune of 15,000 to 2,000 per 20,000 per year. So now the trends, as in 2010, again, the trends have been increasing, and reasons for increasing JE cases, the spread of JE to new states, that is the Jharkhand, Orissa, Manipur, Meghalaya, spread of JE to newer districts within the same state, UP, West Bengal, Maharashtra, and Tamil Nadu, and increasing cases from India adults which were not vaccinated, that is the Uttar Pradesh, West Bengal, and Assam, which I was talking about earlier. Also, there have been small rising epidemics in pockets of these states. Especially in Gorakhpur, in the past, they had to vaccinate a huge cohort of population in that particular districts. Increasing surveillance reports. So the increasing footprints, again, Maharashtra, out of 27 cases reported, 27 cases of outside endemic zone, that is the Pune, Jalna, Raigad, Parbhani, Usmanabad, Cholapur. So various districts of Maharashtra are identified. Jharkhand, again, 18 districts were identified. Odisha, 13 more districts were added to the JE endemic zones. Chhattisgarh, again, more and more endemic districts were declared, and JE campaign vaccination was initiated. Rajasthan, again, previously known to be free of JE, but again, the reports, there are two confirmed reports in 2017, and till date, their cases have been rising. So, JE vaccination for adults, the number of target districts was increased from 21 to 23. The Ministry of Health and Family Welfare has added 37 more districts as JE endemic list to the total of 268 districts across India. So, the epidemiological shift. So initially, this disease has been a disease more of adults, but now there is an epidemiological shift. And as per data from the ICMR, established viral research diagnostic laboratories diagnosed between 2014 to 2017, the data is from all over India. And of these 1,231 cases, more than 40% of cases were in age group more than 15 years. So the epidemiological shift of JE to older children and adults is mainly due to the introduction of routine JE vaccine in the younger children. So nowadays, I still remember in my practice, I've been vaccinating JE since last almost more than 10 years. The epidemiological shift increases, indicates the need for a vaccine and schedule which provides sustained protection for a long term. So again, this is a JE burden which already I have talked about in multiple states of India, and recently affected states, mainly affected states, that the Assam, Uttar Pradesh, Odisha, West Bengal, Bihar, and Tamil Nadu added to the earlier states. So when to suspect a Japanese encephalitis? Friends, child which is aged between 2 to 15 years, these are the most high risk cases when the child is belonging to a rural area or an area with very high mosquito density. So during monsoons, post-monsoon season, proximity to cattle, pigs, or horses. So the most common clinical features which they present is with fever, altered sensorium, and evolving CNS illnesses. So people who are living in endemic rural areas, people traveling to endemic areas during the transmission seasons, healthcare workers, young children under 10 years, more likely to die. So increasingly adult cases are also seen in the endemic areas. So how this cycle, how the JE viral transmission cycle occurs. So there is a reintroduction of the infected mosquito vertebrates. There is a viral amplification in the primates like the pigs and the other birds through mosquito. When the mosquito bites them, then again the mosquito bites the infected blood of these animals, and then they bite to a human, and which is a human and horse, which is a dead end host. So the seasonal distribution, as I earlier mentioned, now if you see, there is a very prominent peak of this disease. The cases, they show a steep rise during the months of August, September, October, and then they start declining. So this has been published in the 2008, 2010, in the second edition in 2012 by Milind Gore. So pathogenesis, again, the Japanese encephalitis virus, it travels to the blood monocyte and tissue macrophages. it transmits to the blood, lymphocytic system, affects, crosses the blood-brain barrier, the CSF, and it affects the neurons, the microglia, astrocytes, causing apoptosis, necrosis, and clinical outcome, which is mortality, that is the death. So the pathogenesis, the incubation period is 5 to 15 days. The virus undergoes a limited multiplication in the host lymphocytes. Majority of subjects eliminate the virus before entering the brain due to development of antibodies which are present only with mild disease. So failure of antibodies against the virus increases the entry of viruses to brain, and these viruses reaches the CNS by leukocytes, that is the probably the T lymphocytes. The JE virus can cause direct neuronal cell death, indirect cell death, by overactivation of microglia and release of inflammatory mediators, that is the TNF alpha, the nitrous oxide reactive oxygen species. The cell death further triggers the release of inflammatory mediators, further increasing the neuronal cell death. So mainly, if you see an MRI, the JE mainly affects the thalamus, the corpus striatum, the brainstem, and spinal cord. So the clinical presentation can be divided into three, that is the prodromal stage, the acute encephalitic stage, and the late end stage. The prodromal stage lasts for 1 to 2 days where high-grade fever, headache, malaise, nausea, vomiting like any other viral illness. The acute encephalitic stage, which is the 3 days, 3 to 5 days with altered sensorium, convulsions, neck stiffness, variable neurological signs such as the cranial nerve palsy, tremors, ataxia, abnormal reflexes, paralysis, delirium, coma could occur in the second encephalitic stage. The late stage, that is from the sixth day, they cause acute inflammation subside, which when the acute inflammation subsides, the neurological signs they destabilize, they stabilize. So complication and the neurological sequelae, more than 50% of survivors, they have motor deficits, upper and lower motor neuron weaknesses, cerebral and extrapyramidal signs, mental retardation, convulsions, speech disturbances, secondary infections like UTI, pneumonia, stasis ulcers. So again, the signs which red flags rather leading to poor prognosis in such cases, with open eyelids, hanging jaws, rapid breathing, excessive secretions, Dalsai movement, pupils not reacting, persistence of fever, absence of response to pain, refractory seizures, decorticate posturing, decerebrate posturing. So the infection outcomes again, 1 in 2050 children, they land up with who are symptomatic, they land up with the morbidities, with otherwise the encephalitic cases. Among the encephalitic cases also, the outcome has been very poor with residual disabilities. In 30% of cases, they recover. 30% there is mortality, and 40% have a residual morbidity and disabilities in lifelong. So how to diagnose it? So it's a mixture of fever, rash, epidemic onset, sensorium altered, focal or asymmetric affection of the neurological system. It is clinically similar to any other acute encephalitis syndrome. The presence of rash generally rules out the JE. Typically presents with focal or asymmetrical neurological sign. So friends, mind it. Always remember, if you find a rash, then it is very unlikely to conclude that it could be a JE. It could be definitely other viral like even herpes encephalitis or other acute encephalitic syndrome. And most importantly, the JE presents with focal or asymmetrical neurological signs. Now, the lab diagnosis, the testing for the JE vaccine specific IgM antibody in a sample of CSF or serum using the MAC ELISA, which is the gold standard or the recommended method, or where in resource poor settings, fourfold or greater rise in the serum antibody titers, isolation of virus, specifically in the microbiology lab from or demonstration of viral antigen or genomic sequences in tissues, CSF, or other body fluids. RT-PCR again is a very highly sensitive and specific test, though it is restricted to very specific centers. Now this is this is a diagram which will depict how the JE virus transmit throughout the blood in the initial days, in the infection phase, in the encephalitic onset, in the CNS and tissues, and in the serum. It comes in the late stage. Why this chart is important? Because this helps in the defining the diagnosis by which type of investigation you should order and at what time you can order them. So the serum and CSF IgM, they can be ordered between the day 4 and day 6 of illness. They can persist till 21 days of illness. And IgG and the HI and neutrophilic antibodies, they may persist even 1 year after the illness. So when to collect the sample for virus isolation within 4 days after the onset of illness. For IgM, it's 4 to 7 days after the onset of symptoms, and two samples are to be collected at the time of admission, at the second sample at the time of discharge or the 10th day of onset of illness. CSF is preferred over the blood sample. Antibodies in the blood may be present even if there is no brain infection or if there has been infection in the past. So, friends, it is very important to know all of us that JE is a notifiable disease now by the Government of India and the Minister of Health and Family Welfare. It has been declared. Neuroimaging, again, JE mainly affects, as I earlier also mentioned, thalamus, basal ganglia, midbrain, pons, and medulla. This is the MRI picture of the JE virus vaccine. And movement disorders are more common sequelae in the JE virus, JE affection. So the management, again, it's more of a airway, breathing, circulation, convulsions, control of convulsions, intracranial pressures, control of temperature, fluid electrolyte balances, general management. Because as such, we don't have a very specific treatment for this cause. Investigations to document it is very important. Reporting is very important. Rehabilitating such a case is very important. Preventing measures, most and first and foremost, is mosquito control in our settings, ultra low volume fogging, pigs control at least 5 kilometers away from human inhabitation. Neither mosquito control nor pig control has been proven to be very reliable public health measure to control JE vaccine. This has been told by WHO in 2014, and they have been published a paper. Vaccination, friends, is the single most important preventive measure. WHO and IAP, they strongly recommend vaccination for prevention, and recommendation of JE vaccine in India. Again, the ACVIP recommends routine vaccine for children up to 18 years living in the JE endemic areas, travelers to endemic and epidemic areas. The Government of India advocates routine JE vaccine for all children in endemic districts with two doses of JE, first at 9 to 12 and second at 16 to 24 months. Though this thing, because this vaccine which is there in the government setup is different from the one which is we practices commercially. The In commercial practice we use the inactivated dose, which is to be given at 1 year, 1 year, 1 month apart, two doses. After 1 year, it has to be given. There are three vaccines which are licensed for commercial use: the live attenuated vaccine from China, the Verocell derived inactivated vaccine, which is the GV in India and internationally available as Ixiaro, Verocell derived inactivated vaccine based on 821564XY strain. So the G manufactured in India with technology transfer from US, it is worldwide available as SA 1442, the world's first JE vaccine to get a WHO pre-qualification. So the, again, what I mentioned, two dose schedule, it is available in 3 microgram and 6 microgram. 3 micrograms till 3 years, above 3 years, it is 6 micrograms. So Jeev in India, the minimum age of use is 1 year. Jeev, again, Pyroxia is one of the most. Jeev and Genvac by Bharat Biotech again is available. Genvac also is a very reliable and authentic vaccine. Again, though they recommend in the leaflets as one dose, but according to IAP recommendation, we have to give two doses 1 month apart. This vaccine has been reported with very less serious side effects. So the long-term immunity data, duration of protection has been documented with a pre-booster and post-booster, and this has been a very robust vaccine, which is with an average protection, which lasts for almost 14 years even after the booster dose. So, friend, this is the time when we should be updated and alert to give this vaccine strongly to our kids who are coming to our clinics. So, again, WHO recommendation: who should not get a JE vaccine? Person who has got a life-threatening reaction to mouse protein, thimerosal, or previous dose of JE vaccine, severe allergy after a vaccine or medication, or pregnant or nursing mothers. JE vaccine, again, to travelers has been recommended. Travelers to rural district of JE endemic areas expected to stay for 4 weeks or more, who are likely to stay outdoors, complete the doses prior to 1 week before the travel. Summarizingly, friends, JE is a deadly virus disease with significant morbidity and mortality. Even the government has to acknowledge the morbidity and mortality of this disease and to introduce the vaccine in the NIP. Endemic recently, endemic in many parts of India with periodic epidemics. It has no specific treatment and only supportive measures work. Human vaccination is the best preventive method. It is safe and effective. Vaccine should be offered to all at risk, and most importantly, children between 1 to 15 years of age. It has a very high safety, immunogenicity, and long-term duration of protection parameters, which has been considered while selecting the vaccine. Thank you so much. And the doses apart as early as can be given as 28 days, friends. Thank you so much. So vaccination is the tool to protect this disease. Thank you so much. Over to you, sir.
Really, it is Dr. Kelkar. It is amazing talk by you, and it is very informative to the viewers and pediatrician. IAP already have recommended the JE vaccine, and your talk will definitely boost the vaccination among the children and the travelers who are going in the particularly in the rural area and in the safaris, those who are going or working uh, in the grounds, those who are working, and it is good for to prevent from the JE because it is a deadly disease and definitely life is threatened by the JE encephalitis. And really, it is really great pleasure that to be with you on
Thank
this
you so much, sir.
today,
Thanks a lot, sir.
and really amazing. And I am sure that all the public viewing this video and the pediatrician and the parents will be enlightened with the talk of young dynamic pediatrician from Indore, Dr. Himansu
Thank you so
Kelkar.
much.
Thank you so much.
Thank you,
Thank
sir.
you to be
Thank
with us, sir. Thank you.
you. Sure. Thank you.